Okay, so here we go with part two, kyphosis, scoliosis, and then pelvic obliquity, what that is about. First of all, with the pelvis, to kind of figure out what we're talking about, we talk about the pelvic tilt. So where on the person is the pelvis tilted? When people are sitting at the computer desk, I'm guessing as you're sitting right now, your posture is probably a little bit slouch. Probably have a posterior tilt. Your pelvis is tilting backwards, or at least flat, probably backwards. Neutral tilt, slight forward, anterior tilt, and an anterior tilt, excessive one, is it's coming too far forward. Posterior, too far back, anterior, too far forward. We'll talk more about this as you kind of progress through the program. It can be very confusing, but it's a key thing around how people move and how people do things, function, and treatment. Where is their pelvis going, so we can kind of fix them and get them and help them do what is important for them to do, function-wise. Okay, so let's break down these different kind of issues with the back and the pelvis that can relate to wheelchair function and really relates to your wheelchair assignment. Because some of your cases, as you look at them, you'll see that they have different problems. Some of them have kyphosis, some of them have pelvic obliquity, scoliosis. You have to kind of consider those issues when you're designing your wheelchair for your patient. Okay, so kyphosis, kind of the curvature of the upper part of the back. They call it kyphotic. Somebody has very kyphotic posture. They're very hunched over. See this a lot of older folks, in nursing homes, that sort of thing. Different causes of it. Schumann's kyphosis is one cause, or progresses through growth. They don't really know what causes it, but kind of inherited kind of genetic thing. Other causes, just a weak core. Your stomach is weak, rounded posture, posterior tilt. Kind of going back this way. Osteoporosis is a very common cause of kyphosis with older folks. Degenerative disc disease in your spine. Muscular dystrophy, weakening of the muscles. Spina bifida, Paget's disease, or just trauma. These are all things that can cause varying degrees of kyphosis. So why is kyphosis a bad thing? Can't really demonstrate it because we're not doing that in class. But it impacts a lot of different things around function. Your upper extremity range of motion. You can't lift your shoulders as much if you're all hunched over. It just limits how high you can lift your shoulders, how high you can reach into the cupboard, how high you can function with your shoulders. It impacts your voice capacity, and even more importantly, your breathing capacity. So your ability to breathe is impacted by kyphosis. Why is that? Just visualize it. It's kind of squeezing, collapsing everything down, or a lung length is just not as good. It's shorter. It's compromised because of the kyphosis. Impacts other organs, impacts your visual field. You cannot see as much. I mean, you're looking down, hard to see. This is an extreme, but her range of vision, her visual field, is very limited because of the severe hunch and deformity in her back. So when you're thinking about wheelchairs and you're thinking about interventions, you have to determine, okay, this person obviously has kyphosis. The next question is it fixed or permanent, or is it flexible? In other words, can it still be moved and improved upon, or is it like a done deal? This is the way it's going to be. It's kind of contracted. You can't really move it. The way to determine that is can you passively arrange them? Can they get themselves back to neutral, this being the kyphosis? And if you can, then okay, there's things you can do. There's exercises you can do around the tilt and the core. But really relevant to this class, there's things you can do to the wheelchair to improve their positioning in the wheelchair so they're not all kyphotic, compromising their lungs, getting pneumonia, and all those awful things. You can do chest straps, shoulder straps, any kind of strap to kind of pull them back. These straps pull them back on the wheelchair, pull them back into neutral. It's a good thing on their body, on their lungs. If your patient for your wheelchair has kyphosis, severe kyphosis, you want to think about some of these to fix their deformity. Other ways of addressing the deformity, this kind of talks about the visual field kind of thing. A tilt system, custom seating, something called a keyhole back, adjustable tension in the backs. Here's some examples of this. This is the tilt in space. It just improves their visual field. It gives them skin relief, and they're not looking down. They get so they can see, loved ones or people visiting them. They can look them in the eye, kind of thing, for this tilt in space. The keyhole back and the kyphosis care back are different versions of special cushions and wheelchair tops here. They can help with the fixed. So you're not really, it's kind of like you're compensating. You're not really fixing, you're not bringing them back to neutral because it's not, you can't move it, it's contracted. But you're making the most of it in terms of skin breakdown, and protecting their body and that sort of thing. With the keyhole back and the kyphosis care and the tilt in space. So if your client is a fixed kyphotic posture, you'd look towards these kinds of solutions for your wheelchair paper. Scoliosis. I think a lot of us are familiar with scoliosis, the curvature of the spine, different degrees of the curve. This is the kind of the words, the double major curve. A lot of people have subtle variations of this. Lumbar region, thoracic region, unknown cause really, byproduct of numerous diagnoses, but not limited to, again, muscular dystrophy, cerebral palsy, arthritis, leg length discrepancy, one leg being longer than the other, can lead to scoliosis. Again, we have to think, okay, is it a fixed deal, or is it still flexible? Can we bring that person back to neutral? If we can, then we can kind of go to town with different adaptations to the wheelchair, curved wheelchair back, these lateral supports I was talking about. For Stacy, because of her weak core, it's also good for scoliosis. So again, if your wheelchair person has scoliosis, think about the chair is going to need lateral supports. Custom seating kind of stuff. If it's fixed, we're kind of compensating. Again, we're thinking tilt in space, contoured or modeled back, horizontal, different kind of tilt systems. They can kind of engage and see the world. The next one, the third one to think about is the pelvis position, something called pelvic obliquity, which is how symmetrical the pelvis is. So this guy has a pelvic obliquity. Basically, one pelvis is higher than the other. Here it's subtle, this one's higher. Here, this one's higher. It's not straight across like it is with most of us. You would assess this if there's like the little dimples on your backside and your buttocks. You can just put your fingers on them and line them up. Is it straight across, parallel, or is it tilted one way or the other? If it's tilted one way or the other, you have what they call a pelvic obliquity. One side is higher than the other, basically. Here's a good picture of it. It's called a right. It's kind of backwards, but they call it a right because the right is lower than the left. So it's a right pelvic obliquity. It's named after the low side. Inside the right side is the low side. Can cause by the leg length inequality, hip contracture, scoliosis, or combination of causes. Even like tightness. A lot of people have tightness in their hip flexors from sitting all day, especially if they're one side more than the other. It can cause this obliquity in their hips, in their pelvis. Okay, so if it's flexible, which it usually is, you can do certain things about it. Kind of what you would think. You can do a cushion that compensates for the tilt to kind of level them off. A cushion and pad, kind of example. These are two examples of that. And you can change the pull of it through the belts kind of thing. Exercises. So you need some kind of pelvic obliquity cushion to address that issue that was going on with your client. All right, so it's